Stephen, thank you for giving us the opportunity to speak with you today. I think it's interesting and really worthwhile to sit down with somebody who's researching pancreatic cancer, particularly with the work you're doing on early diagnosis. And of course, early diagnosis, I think, in any cancer is really, really important. But particularly in pancreatic cancer, I think the statistics are the 5-year survival rate is 5%. So diagnosing pancreatic cancer early is absolutely vital. So just to start off with, and a very simple question, or maybe it isn't, it probably isn't, but what does the pancreas do and what causes pancreatic cancer?
So the pancreas is an organ just like, kind of lung or liver or anything like that, but it's positioned right behind your stomach, next to your spleen, in front of your spine. So it's sort of embedded right kind of in your abdomen. But it has a few different functions. So one of the functions would be to produce insulin, which helps keep your blood sugar balanced. And one of the other functions then would be to produce digestive juices into your gastrointestinal system, into the intestine to help digest food from the stomach. So pancreatic cancer, as you mentioned, has a very, very poor prognosis. Most of the patients, about 75% of patients who will be diagnosed don't survive beyond a year, and a lot of them substantially less. We don't know exactly what causes pancreatic cancer. We have a lot of risk factors that we know to be associated with pancreatic cancer. So this would be smoking, alcohol, diet, lifestyle, so obesity, and maintaining a healthy weight can reduce your risk. And I suppose those wouldn't be very particular to pancreatic cancer. They'd be more broadly applicable to cancer. And those would be modifiable, I suppose, risks that can increase your risk of developing cancer. And then we have sort of, genetic components where we're not exactly sure, of the kind of repertoire of mutations and genes that are involved in the development. We know certain mutations in certain genes increase your risk of developing pancreatic cancer. And we know that certain kind of hereditary conditions, for example, chronic pancreatitis, which would be inflammation of the pancreas, increase your risk of developing it. But there's no one particular thing that actually increases your risk. So we don't know all of the causes of pancreatic cancer.
And so that's why it's so difficult to diagnose and diagnose early. From my perspective and my story, well, my wife's story, Stella, Stella passed away in July 2022. She had been experiencing symptoms, well, we now know there were symptoms probably 9 months before that, where she had abdominal pain, she had some lower back pain. She was also diagnosed with early onset diabetes, but there was no connection, and we had no idea of what those symptoms were until it was too late. And she was diagnosed on the 20th of May and passed away 8 weeks later. So, not having the understanding of those symptoms, I suppose, is a huge factor in not getting the early diagnosis for a lot of people. I would suggest as well. Do you find that is the case, that the lack of information that's out there? Because I think if I had known what those symptoms were, we would have connected the dots, and maybe the doctors would have connected the dots a little earlier, and we might have had a little different outcome.
Yeah, it's a very tricky one. I suppose hindsight is always kind of 20/20, and then when you get a diagnosis, say pancreatic cancer, you look at these symptoms and you're like, oh, it fits. Unfortunately, with pancreatic cancer, a lot of the symptoms that arise, particularly actually when patients become symptomatic, it's the disease is usually quite advanced, for the vast majority of patients. But ultimately, the sort of symptom profile, they're quite vague symptoms. You might have nausea and vomiting, a lot of the time, but maybe just nausea, kind of upset stomach, which can be attributed to a lot of other things. We know that as people, as we get older as a population, once you get into your 40s and 50s, the incidence of cancer starts to increase kind of substantially over the younger population. But that increase in age also kind of comes with aches and pains and things like that. So having kind of back pain or abdominal pain, unless it's very severe, we'll tend to kind of brush it off as probably something else. You don't naturally attribute it to pancreatic cancer. But when we do look at the symptoms, the known symptoms, fatigue, kind of depression.
That's what Stella was, her doctor suggested maybe that's, what she was suffering from as well during that period of time as well.
And I suppose, you're looking at kind of putting together, a few different symptoms and knowing that they're the symptoms of pancreatic cancer. Not every patient gets every symptom. So, not all patients will get jaundice. It depends within the pancreas where the tumor arises.
Would you say it's the hardest cancer to diagnose, or is that a very sweeping kind of statement?
I suppose it depends on what you mean. Is it difficult to diagnose? As in, is it difficult to diagnose early? It is absolutely very difficult to diagnose early. Other cancers can be quite very, very rare cancers, that are even rarer than pancreatic, can be extremely difficult to diagnose. The big problem for pancreatic cancer is that it is difficult to diagnose early, because most patients, once they've developed symptoms that indicate there's something wrong, it's usually advanced.
It's advanced. So your research, and it's great research, is on looking at early diagnosis. So what are you doing, and ultimately what are you trying to achieve, and is there a holy grail?
So I suppose, ultimately research is what's going to change the face of pancreatic cancer, and there's lots of different ways that you can tailor that. So even if we think about modifiable risk factors, increasing kind of awareness of adopting a healthy lifestyle, quitting smoking, reducing alcohol intake, ideally, no alcohol. Increasing, fruits, vegetables, all the good stuff that we know makes a difference, not just to pancreatic cancer, but across the board. Increasing awareness of the kind of the symptom profile for pancreatic cancer. So making, people aware that, these are the symptoms of pancreatic cancer, and, if you have these, you should go to your GP, and even in increasing GP
awareness as
well. And training in recognizing pancreatic cancer, in terms of the symptoms, and not just assuming, because a patient is young or, is female, or that they are at lower risk, but that it doesn't mean that this can't be part of the problem.
Do you think there's a gap there? Do you think there's a gap in terms of primary healthcare professionals understanding the symptoms of pancreatic cancer? Or because I think there's another statistic that says that a GP will see one case of pancreatic cancer every 5 years. So it's just so unusual. So do we need to do better and more with helping primary healthcare professionals understanding the symptoms?
Yeah, I suppose, it comes from both sides. I mean, if you look at a GP and how many patients are going through a GP office, every day, and you'll be having people who are like, have feelings of depression, or have itch, or, nausea, vomiting, that are attributed to other things. So GPs, they've got a lot of people coming through their clinics every day. They're going to have, a lot of these patients are going to have symptoms that, you could put, side by side with pancreatic cancer, but, these patients are going to have something else that is not, pancreatic cancer. So the number of pancreatic cancer patients that will actually go through a GP office is going to be, very, very few. When you look at symptom profiles, similar to pancreatic cancer, the odds are that it's not going to be pancreatic cancer. So I suppose it's just being able to identify, better, when there are particularly worrisome symptoms, and something that might need to be followed up, with a specialist through, additional testing.
Sure, yeah. And then from I hear things about breath tests and blood tests and everything. Where is your research centered around in terms of early diagnosis, and what are you finding?
Yeah, so I work with a gastroenterologist. She's a fantastic clinician, Professor Barbara Ryan. She's based at Tallaght University Hospital, and she's a professor here at Trinity College. And Barbara would see up to 100 patients a year that would have pancreatic cysts. So these would be, if you imagine like a blister, it's a fluid-filled structure that can be found inside the pancreas. And we know that a proportion of these have malignant potential. They have the potential to develop into cancer. And then the vast majority of them would be low risk, but we know that some are high risk. And I suppose what's worrying is that most of these cysts are actually found incidentally. So when patients come into a clinic or go into the hospital and they have either an MRI of the abdomen or a CT scan, the vast majority of these cysts are just picked up as a side to whatever was actually been investigated. And in the generalized population of adults just walking around, about 2% of them, so 1 in 50 will have pancreatic cystic lesions, and we know that the incidence increases as the population gets older. So by the time you're 70, anywhere from 10 to 20% of adults have pancreatic cysts. So,
but not all of those will mature until.
Yes. Yeah. So who do you follow? Who are at high risk? Who are low risk? So one of the things that my research program is looking at is identifying better who are high risk and who are low risk. So who we know to watch more closely, and who we can look kind of get them to come in every three years, for example, instead of every year. To be assessed. The assessment for looking at these pancreatic cysts is actually quite invasive as well. It's an uncomfortable procedure. So we're trying to develop less invasive kind of blood-based assessment for stratifying patients into risk categories. We're also trying to understand the biology of these cysts as well, and trying to understand, are they just a byproduct of what's happening in the pancreas, as part of the disease process, or do they actually help drive the disease, and do they contribute to the development of pancreatic cancer? So, why some cysts are actually high risk and why some are low risk, and how does the biology kind of dictate who progresses to cancer and who doesn't?
Yeah. And data, obviously is really, really important. Is there enough data in this country to kind of help you with your research? Is there a data deficit? I know we talk about biobank, and having enough information for you to do your work really well. Is that something there is a deficit in this country for?
Yeah. So in terms of the numbers of pancreatic cancer patients that would be diagnosed each year in Ireland, it's about 600, so probably a little under 600 patients. So it's almost what we call a common rare cancer, in that there's a significant number of people been diagnosed, but when you think about the stage that all of those patients will be at, some will be approached with curative intent, some will get chemotherapy, some will get radiation, some will get combinations. When you filter these patients into different sort of management brackets, there's relatively small numbers, in each of these. And when you couple that, unfortunately, to the fact that, most patients don't survive beyond a year, it's very difficult to do studies within the pancreatic space, within the pancreatic cancer space, in large numbers, so it really, in order to, I suppose, change the face of the disease, we need as many people enrolling into clinical trials. we need multi-center trials, so multiple institutions, multiple hospitals around the country, and then extending kind of into larger European sites as well to really build up the numbers and study it.
Who would enter into those clinical trials? I mean, is it people that are at risk, high risk, or is it people that have actually?
Well, I suppose in terms of pancreatic cancer, it will be patients who are diagnosed. In terms of patients who would be say have like a familial risk or an increased risk.
So screening.
Pardon?
Screening, would that be?
So screening. I mean, when we think about the genetic, so cancer is a genetic disease. It's caused by damage to the DNA inside cells to the point where they become cancerous. For pancreatic cancer, we don't know enough about the, I suppose, specifics of the mutations and genetics that are specifically associated with pancreatic cancer. We do know certain mutations in certain genes like BRCA, which you might have heard of. It's largely thought of as the breast cancer gene. But patients with BRCA mutations would be at increased risk of developing a whole variety of cancers, including pancreatic, ovarian, for example. So we know some mutations that occur in generally across multiple forms of cancer, but are not specific to pancreatic cancer. But ultimately, surveillance for pancreatic cancer, now that more patients are getting scans, CT scans and MRIs, increasingly we're detecting more of kind of these cystic lesions in the pancreas and seeing kind of abnormalities before patients become symptomatic. But ultimately, scans and that, they take a lot of clinical time to do, a lot of expertise to look at. So identifying and developing less invasive, less intensive kind of strategies. So looking at kind of blood-based surveillance is probably where we need to be moving into, for these particular patients.
So do you see screening as being a very important part of that whole process around trying to diagnose pancreatic cancer early?
Yeah, so I mean, we know from like most cancers that, kind of early intervention, early diagnosis and screening make a difference. And, the same would be true with pancreatic cancer. So we have some, say, blood-based markers. One is called CA19-9, which is typically used alongside other sort of metrics and other measurements in patients to diagnose pancreatic cancer. And it's a marker that we see in the blood, but it's not very effective, on its own at actually diagnosing pancreatic cancer. So we need to develop other kind of other markers in the blood, which is part of what our research is doing. We also know, I suppose, more recently that monitoring, say, increasing levels of blood sugar and kind of the development of this diabetic kind of trait is something that we can see in the blood of patients, before they get diagnosed. So I suppose, as part of normal health monitoring, we need to start building in, as opposed to blood tests that are done routinely for patients, something that could make the difference.
And that's probably for people who are at risk, who have family.
Yeah, so for people who are at risk, this would make sense, to keep a closer eye on.
Is that happening anywhere else outside of Ireland? I mean, are we behind in terms of what's happening internationally?
I don't think we're not behind. I think anything that's happening internationally. I mean, in all of the kind of the centres within Ireland, we would use standard of care, which is kind of the internationally recognised kind of best practice. What you do have, obviously, is patients at on a spectrum, I suppose, of stage, when they're diagnosed or as they're managed, which and because there aren't massive populations of patients with pancreatic, research can move, I suppose, a little bit, but slowly, but in terms of its management, research is really going to change how patients are managed over the next 20 years. There's also, within different spaces, so for example, with looking at these pre-malignant cysts that I was talking about, internationally there's 3 different sets of guidelines as to how patients should be managed on that. So there isn't international consensus there. So we use the European guidelines. Or for example, in the United States, they would favor, say, radiotherapy for tumors in the pancreas, whereas there's less enthusiasm for that here in Europe. So there's still a lot to, I suppose, thrash out in terms of the research into what is actually the best way to manage patients.
So, they say hope isn't a strategy, but, for people like me who has been affected by pancreatic cancer with losing my wife and those who are, being diagnosed and those who are working through, what does 10 years look like? What do you think we will see in 10 years or 20 years? You mentioned that earlier on. What can we expect and what can we hope for?
Yeah, so I suppose in the last 10 to 20 years, if you look at how pancreatic cancer, I suppose, survival rates have changed, there's been an increase, but it's been, very kind of minimal. But with all of the new technologies and personalized medicine, our understanding of the biology of cancer, and our ability to look at biology of cancer, there's huge amounts of research been done across the globe, ourselves included, in those particular areas. So, key to tackling anything is understanding the biology of tumours. So, my research group would be looking at altering, treatment sensitivity. So, the vast majority of patients will get chemotherapy. We're looking at how cells are resistant to chemotherapy, how we can manipulate them to be more sensitive to treatment. Tumours of the pancreas are what we call immunologically cold tumours. So, the immune system tends to recognize tumours. If you look inside pancreatic tumours, you don't see an awful lot of immune cells, so the immune system seems to be excluded from them. So there are new kind of immunotherapies that are being developed to change, I suppose, the immune profile of tumours to make them, I suppose, more sensitive to immunotherapeutics and more personalized medicine. But really, improving early, I suppose, intervention. So recognizing symptoms, that's early, and getting to patients at an earlier stage of disease is going to be absolutely vital. And then improving the sensitivity of these tumours to conventional therapeutics that we know work in so many other types of cancer. Getting those to work in pancreatic tumours and just managing them better are hopefully big strides that we're going to make in the next 10 years.
Good. So it seems like a multifaceted approach from, getting early detection through identifying symptoms early, but then, the research that you're undertaking, the great research that you're undertaking.
So trying to prevent it, in patients and getting to it early before it becomes a problem. And then for patients who get diagnosed with pancreatic, being able to tackle it more effectively.
And I get a sense that there's a lot more momentum now in Ireland around this, and I'm sure there's always been, we've always wanted to improve it, but there just seems to be more momentum around pancreatic cancer and focusing on that disease in its own right.
Yeah, well, pancreatic cancer, it would have, very poor survival rates. It's set, in the next, I suppose, by 2040, it will become the second leading cause of cancer deaths, not just in Ireland, but probably in Europe. And as a cancer, I suppose, of unmet research need, organisations like Breakthrough Cancer Research, have really started to help channel a lot of funding into these poor prognosis cancers, which is absolutely key to changing the outcomes for patients, over the next few few decades.
Okay, well, Stephen, thank you so much for your time today. I've learned a lot, and again, thanks to Breakthrough Cancer Research as well for bringing this together. I think it's really important and really beneficial. So again, thank you so much for your time.
You're quite welcome.